Good morning. This is my disclosure. So it's more than 10 years now that we are trying to give the best therapy to our patient with drug-eluted balloons and drug-eluted stent. And we have several randomized trials that are supporting us in this, but unfortunately the real-world practice is still limited, and it's still limited node, because we still need long-term follow-up for our patient, in particular for new drug therapy. When we think about the main study who analyzed the real-world practice for a drug-eluted balloon with paclitaxel, it was the IMPACT global study. And it was a real-world study, prospective, multi-center, who analyzed the treatment of complex femoral popliteal lesion. And the aim was to analyze the outcome for adverse event and CDTLR in the coming year. It was more than 1,400 patients enrolled, more than 1,700 lesions that were studied, and there were 35 total occlusion, and the calcified artery was almost 70%. But what was seen through the study, through the study was possible to analyze a different category of patients, the patient with de novo in-stent stenosis with long lesion and CTO. And what they seen that the results they were good, with at least promising for complex lesion, still a little bit slightly lower for the in-stent stenosis because the lesions were very complex, but still promising result also for CTO. And also the freedom from all-cause mortality through 5 years was analyzed. And again, there was no safety issue with these devices. Not all the time when we want to treat our patient, we are satisfied with what we achieve with plain balloon and with drug-eluted balloon. So we need to stent now and then. And also this kind of patient were analyzed in this study is comparing the stented versus non-stented cohort of patient. And in both the situation, the results were consistent. So even when we need to implant a bare metal stent, the result at 5 years can be similar for these two cohorts of patients. But what is the limit of main study? What we don't know yet is how is the delivery of our therapy and the result of our therapy with drug-eluted solution are with for claudicat patient or for CLI patients. So also through this study was possible to analyze these two different populations. And in particular, we've seen that the freedom from CDTLR through 5 was of course slightly better for patients with with Rutherford 2 and 3. And for more complex patients, we have a significant difference in the mortality at 5 years. But what's really important, how we can save the limb, how we save the liver of our patients. So for a limb salvage through 5 years, the result was was significantly better for Rutherford 2 and 3 compared to 4 and 5, but at least we can save almost 90% of the limb of our patient. On the other hand, as already mentioned by Marta and Mariano before, Limbus technology came on the scene, and we are still far from having randomized controlled trials on that, but many studies, they can already help us. So this is one of those, the two technology available. This is a study with Magic Touch for femoral popliteal L below the knee lesion, and these are the results just published at 3 years, and we could see that we could have an overall freedom from clinical-driven target lesion revascularization up to 84% of the patient with good survival rate for both the patient with both the popliteal and BTK lesion, and freedom from major amputation up to 86% in overall population, and a free amputation rate of almost 60% for BTK lesion. What are the results available so far for the other balloons, so the solution technology? We have this first in-human clinical trial about the femoral popliteal lesion, 50% de novo femoral popliteal lesion only, and the primary patency at 12 months was 88.9%, and we have an amputation-free survival at 24 months of all the patients. The Prestige study was mainly focused on task 2C and D tibial occlusive disease, so only BTK lesion, long lesion, 19 centimeters plus minus almost 10. So in this case, what was really good to appreciate is the wound healing at 3 months, but consistently at 6 months with 81% of wound healing. But we don't, despite the technology, despite with what we can deliver with this drug-eluted solution to our patient, we still have problems. Not all the patients responded in the same way to our therapy. And this was an analysis on which can influence our result in this patient, that we seem to treat all in the same way, but actually we don't achieve the same goal. And they could see that for each of these goals, so for the patency, for the target lesion revascularization, and the risk stenosis, there are some factors that influence our outcomes. And in particular, when we have 2 or more of these risk factors, our result can be really limited, even if we deliver the maximum that we have for our patient. So, according to what we know so far, the drug-eluted techniques, they can help us in femoropopliteal lesions. Still, we are far to know a lot about BTK, but the result, they are promising, in particular with the new with the LIMUS technology for below the knee. And we have always to consider the risk factor of our patient to really understand what we can achieve, what goal we can achieve for them. On the other hand, we have also, they are not mentioned yet today, the drug-eluted stent technology. We have 2 main stents so far, the silver PTX from Cook and Iluvien from Boston. And still, we are dealing to know what they can really do for our patient. And we have some randomized controlled trial. They are the silver PTX that was analyzing the result versus plain balloon followed by bare metal stent, Iluvien versus silver PTX, the imperial study, and Iluvien versus bare metal stent. So the silver PTX was a randomized controlled trial to check the durability of the silver PTX for femoropopliteal lesion in more than 400 patients, mainly claudicant with not that long lesion, but silver PTX provides sustained safety and clinical durability at 5 years. So at 5 years, all the primary patency and the clinical-driven target region revascularization and freedom from TLR were better for drug-eluted stent technology. But still, is this optimizing our therapy? It's still better to go for a drug-eluted stent or go for a bypass. So this study was focused to understand if the drug-eluted stent, like silver PTX, they can achieve better or at least the same when compared to bypass. So it was a randomized controlled trial again, more than 200 patients, task C and D lesion, quite long lesion, occlusion in 94% of patients, and more of the half of these patients with Rutherford 5 and 6 in both the group. And the silver PTX was non-inferior when we're talking about primary patency to above-the-knee bypass for the patient. From the imperial trial, it was the prospective randomized controlled trial to check the primary patency for Iluvien stent when compared to silver PTX from Cook at 12 months. Again, it was shown it was a non-inferiority study, but again, the Iluvien stent shows superior primary patency when compared to silver PTX with significantly lower TLR. And finally, this randomized controlled trial was focused on determining the primary patency of Iluvien stent versus bare metal stent at 12 months in femoropopliteal lesions. So we know now, we should know now from randomized controlled trial that the technology is working well. There's one stent that seems to perform better than the other one. Seems that the drug-eluting stent, they are better, they are not inferior to bypass solution when compared to above the knee. So what about the comparison with bare metal stent? And actually, this study showed that, again, the Iluvien is the first drug-eluted stent that was demonstrated superior according to the 1 year primary patency when it's compared to any market available bare metal stent. And in this multicenter prospective sorry, I will back. So these are my take-home message. The drug-eluting stent have been proven superior to standard care and bare metal stent for stenosis. The pathology and the clinical-driven target lesion revascularization 5-year are in favor of drug-eluting stent. For the best, for optimizing our therapy, we always should consider the patient factors, and we are the new devices and the alternative agent seems promising in the next future. Thank you.